Hello everyone, good evening. I hope I'm audible and visible now. If yes, kindly give me a quick thumbs up. So I hope the relay is fine now and there is no problem at the moment. If it is, kindly let me know. So before we begin the class, wishing you all a very happy Christmas and wishing you all a very happy New Year, and I'm sure that the coming year is going to be really prosperous and I wish the best for you. And we've seen 2022 was a very good year, at least compared to 2020 and 21 where we had COVID and the pandemic running. So at least compared to those years, this year's was definitely much better in terms of health, in terms of meeting people, in terms of traveling, in terms of education, in terms of being mentally stable. So I think every which way we've achieved bigger heights in 2022 as compared to our previous year. So I think we need to grow each year, measuring the success of that year and not unnecessarily comparing ourselves with others. So just see where you are today and what you're going to be tomorrow and what are your plans for tomorrow, and just strive to achieve that. So with this message, I will begin my class. But before we begin the class, just for a funny banter, I would like to know what are your plans for the new year. What are you planning to do? Have you all made some resolutions? If you have made, then what are they? Okay, so I'm waiting to listen from all of you. Okay, so while you guys message me about what are your plans, let me go ahead and discuss to you what we have on Unacademy. So we have Dream Big for 2023. So this is a batch course which is giving you 23% off on all Unacademy Medical PG subscription. So you'll get 23% off whatever duration you take. And we have NEET PG Vitals. Please do go and look for my recorded videos of ENT. I have really put a lot of effort, really put a lot of time in making all those videos. There are line diagrams, there are flow charts, there are images, there are MCQs discussed after each and every topic. There are so many things that are conceptually taught to you. So I at least have a idea of what is happening there, so that it will help you. So at least ENT, I want you to have at least one look before you decide yes or no on that. Okay, so let's have understanding upon access to recorded videos in the comprehensive NEET PG preparation. We have phase 1 and phase 2, phase 3 available from January and February. So phase 1, about 15 subjects have been launched, so 12 subjects, sorry, and the rest of them will be launched very soon. So we have final summit batch, module 1, module 2, module 3. Module 1 was for December, which we finished. Module 2 and module 3 are going to happen in January and February. So we are going to do frequently forgotten volatile topics and most expected questions here. So with this quick understanding of what we have on offering from Unacademy, let us go to the images, to the must know images that you should definitely know in ENT. Okay, look at this image and tell me what could be your diagnosis. Today it's not an MCQ session. Today the session is only on looking at the image and getting to the answer, because whenever you have an IBQ or an image based question, you must know what is the answer, what's the diagnosis, or what is it that the image is describing you about. The question comes later, but if you're not able to relate to that image, then you will not be able to answer the MCQ. So first thing first, get your diagnosis right. So tell me what is your diagnosis here looking at the image. I'm waiting for all of your answers in the chat box. Yes, so please tell me what is your answer here. I'm waiting for your answer. So you see, this is the tympanic membrane. The tympanic membrane is showing you something. So what is your answer here? Yes, Grace, it is congested. Congested means it is reddish. You can see the blood vessels radiating from the periphery to the center. You can see some area that has got bulged up. So you see there is an area that has got bulged up. So when you have congested tympanic membrane, blood vessels radiating from periphery to center, and you have minimal bulging of the tympanic membrane, in which disease would you see such a condition? Typically we call this as a cartwheel appearance, and this cartwheel appearance is in one stage of the disease, and as the disease progresses you will get a bulging tympanic membrane. So here what we are seeing is a transition between cartwheel to bulging. So what disease are we talking about? Yes, so what are we talking about? We are talking about acute suppurative otitis media. So what is acute suppurative otitis media? Acute suppurative otitis media is a condition which is a bacterial infection of the middle ear, most commonly caused by Streptococcus pneumonia, usually seen in young children and infants because it is caused by eustachian tubal dysfunction. Eustachian tube being shorter and straighter in younger children, there is reflux of the contents from the nasopharynx to the middle ear, causing middle ear diseases commonly in children. Now this happens acute, less than 3 or 4 weeks duration. Suppurative is bacterial infection. There are 4 stages. Stage of tubal occlusion, stage of pre-suppuration, stage of suppuration, and stage of resolution. So in stage of tubal occlusion you will just see mild retraction. In pre-suppuration you will see gross retraction with blood vessels radiating from periphery to center, which we call it as the cartwheel appearance. Then in the stage of suppuration you will see bulging tympanic membrane, and in the stage of resolution you will see that there will be perforation with pulsatile otoria reflecting light, which we call it as lighthouse sign. So this was a quick brief description of the disease that we were into. Okay, so let's go into the next image. Look at this image and tell me what is this. Good evening Rishi, good evening Prince. So look at this and tell me, I will mark certain structures. What is 1? What is 2? Here you see a projection like this. What is 3? What is this structure 4? What is this structure 5? What is this structure 6? And what is this structure, here, this one, structure 7. So identify and try to tell me. Yes, so this is basically a perforation that you see in the tympanic membrane. So there is a perforation or a hole communicating the external ear with the middle ear. So through the perforation you are able to see the structures of the middle ear. So the first thing is, what type of perforation is this? So is this perforation occupying only one quadrant of the tympanic membrane, or is this perforation occupying 2 quadrants or all the quadrants of the tympanic membrane? So if you see, the perforation is occupying all the quadrants of the tympanic membrane, but do you see this ring, the fibrocartilaginous ring, which we call it as the annulus? This annulus is intact. So if you see, I'll highlight the annulus, you can see this annulus is intact. So when this annulus is intact, what do we call this as? We call it as subtotal perforation. So any perforation in the pars tensa which occupies all the quadrants but the annulus is intact is called as subtotal perforation. If the annulus is also destroyed, then we call it as total perforation. Now we see that the edges of perforation are non-healing type. So it is a chronic suppurative otitis media. So when you get a non-healing perforation, you must think about a CSOM. So CSOM will present to you with non-healing perforation. So this is a typical CSOM with a subtotal perforation. Now what are the structures that we can see? So Gowda and Sharon have answered. One is handle of malleus. So okay, so this is correctly the handle of malleus, this structure. This is the short process of the malleus, neck of the malleus, and we cannot see the head of the malleus because it is in the pars, behind the pars flaccida in the epitympanum. Now this head of the malleus articulates with the body of incus, which again we are not able to see here because the pars flaccida is covering it. We don't have a perforation in the pars flaccida, and this continues downwards as the long process of incus. So the structure number 2 is your long process of incus. Now this incus goes and articulates with the head of stapes. So this is your stapes. To the neck of stapes attaches the stapedial tendon. So the number 4 structure is your stapedial tendon. This stapedial tendon arises from the pyramidal eminence. So this projection that you see here is the pyramidal eminence from where you have the stapedial tendon origin, inserts to the neck of stapes. Now this stapes goes and sits below on the oval window. So this is the area of your oval window. So the number 5 structure is your oval window. This structure below is your round window. Number 6 is your round window, and number 7 is your eustachian tubal opening. This projection that you see here is your promontory. Promontory is the impression formed by the basal turn of the cochlea. So that is your promontory. So I hope everyone is able to recognize all the middle ear structures through the perforation. I hope yes. So if yes, please let me know in the chat box that you understood about the structures here. I am waiting to listen from you in the chat box. Okay, great. So now that you understood this, let us go to the next image based question. Now look at this image and tell me what is your diagnosis based upon this image that you see here. Great. So I am seeing the answers as yes. So let's go to the next image and let's understand what is the next image talking about. This is something that must hit your brain or strike your mind immediately as soon as you see it, because it's something that is very, very commonly seen, very pathological and very diagnostic, and you will get this sort of questions in your exam also. So very good. Prince Davis, Alok Soni, Adraf Shafi, Grace Sharon, very good. This is a image showing you multiple perforations of the tympanic membrane. So when you get multiple perforation of the tympanic membrane, the only diagnosis that you will consider is tubercular otitis media. I mean, there can be many other causes, like even trauma can cause multiple perforation, but the most common cause for multiple perforation is tubercular otitis media. Now tubercular otitis media is characterized by some important things like pale granulations. Normally if it is a cholesteatoma or if it is a CSOM, there are red fleshy granulations, but in tubercular otitis media you get very pale granulation. The hearing loss is disproportionate. What do I mean by hearing loss is disproportionate? Meaning if you see there are perforation in the tympanic membrane and this must result to you in some amount of hearing loss, but the amount of hearing loss is much higher than you would anticipate. So typically here you would expect to have about 40 to 45 decibel of hearing loss because there's a perforation in the tympanic membrane, but in this situation what you would get is more than that. So that there is a disproportionate amount of hearing loss as compared to the disease that you see in the middle ear. So you must always remove the disease from the middle ear and also start anti-tubercular therapy for tubercular otitis media. Okay, so this is about the image. Let's go to the next image and understand the next image. Yes, so look at the next one. Very good, Prince Davis. What about others? I'm waiting for everyone to answer. Yes, very good. The answer is glue ear. It is also called as non-suppurative otitis media. It is also called as serous otitis media. It is also called as secretory otitis media with effusion. All of them mean the same. The hallmark or the diagnostic feature of glue ear is presence of air bubbles. So if you see air bubbles in the tympanic membrane or air fluid level in the tympanic membrane, then you must think about tubercular otitis media. So I don't know why my pen is jumping without me even writing anything, so just excuse me for that. Yes, so there will be air bubbles and air fluid level. This is hallmark of glue ear. Okay, so there are many other appearances. The tympanic membrane may be thick, it may be thin, there may be it may be appearing grayish, it may appear amber black, it may be bluish, it may be bulging, it can have loss of cone of light. There are multiple features of serous otitis media, but the most common feature is air fluid level and air bubbles. That is hallmark of this particular disease. Okay, let's go to the next one. Look at this image and tell me what is the answer. What are you seeing here? There is something very diagnostic over here. I'll give you a clue. A whitish mass behind an intact tympanic membrane. Very good, Harita. When you see a whitish mass behind an intact tympanic membrane, the first and foremost thing that must hit your brain is congenital cholesteatoma. So congenital cholesteatoma presents to you with whitish mass behind an intact tympanic membrane. So congenital cholesteatoma is something that you must think about when you see a whitish mass behind an intact tympanic membrane. There is a criteria for this, which is called as Levinson's criteria for congenital cholesteatoma, which says that whenever you examine a patient with congenital cholesteatoma, you must see a whitish mass. There should be no prior history of any otorrhea, any ear discharge, any ear disease. There should be no prior history of any infection. There should be no otological surgeries that the child must have undergone. Then only you label that patient as congenital. Otherwise, it comes into acquired. So this is a particular disease that is confined only to the middle ear or to the petrous apex or to the cerebellopontine angle. So these are the three locations where you can have congenital cholesteatoma: middle ear, petrous apex and the CP angle. Three locations. Okay, and the criteria is called as Levinson's criteria for congenital cholesteatoma. So it is called as Levinson's criteria for congenital cholesteatoma. Okay, so let's go to the next one. Look at this image and tell me what do you think is the diagnosis over here. What do you think is the diagnosis here? This is something that is also showing you an arrow and it is indicating you certain disease is happening over here. Yes, so this is called as, this is your acquired cholesteatoma. Now all those who are saying keratosis obturans is a condition of the external auditory canal. So there you have whitish mass of keratin which will accumulate in the external auditory canal because the squamous epithelium is not able to come out. But in an acquired cholesteatoma, you will see that it's a pars flaccida retraction. In that retraction, you will see some squamous epithelium that is present. So the presence of keratin debris or keratin flakes in the pars flaccida retraction pocket is suggestive of acquired cholesteatoma. Okay, in aticoantral type of CSOM, Harita, you will also see typically pars flaccida disease, but when you see keratin flakes, it is more suggestive of cholesteatoma, whereas an aticoantral type of CSOM would have either granulation or either there would be purulent discharge, and you may have to see, or you could probably see erosion of the scutum. These features are for aticoantral type of CSOM, but keratin flakes is specifically for cholesteatoma. I hope you got it, Harita. Okay, look at this and tell me, I'll give you a clue here. There is something that you see through the tympanic membrane. It is called as the flamingo pink appearance. Of the promontory seen through the tympanic membrane. What is this sign called as? What is this sign called as? Flamingo pink appearance of the promontory seen through the tympanic membrane. What is this sign called as? Let me just reset my pen tab because it's jumping too much and the handwriting is not coming really neat. Okay, so what is this sign called as? This is called as Schwartz sign. Arun, this is not rising sun appearance. I'll show you rising sun appearance in one more image, but this sign that you see here is called as the Schwartz sign. Schwartz sign is seen in an active focus of otosclerosis. So when there is an active otosclerotic focus or active deposition of the bone happening in otosclerosis, so when you have an active focus, you will get this Schwartz sign positive. So it is seen in a condition which we call it as otosclerosis. So in otosclerosis, there is a active bony deposition that is happening around the foot plate of the stapes. It is not a dense bone, it is a spongy bone. And since it is a spongy bone, you will be seeing when there is an active deposition, there will be an osteoclastic and an osteoblastic activity happening. And because of that release of inflammatory mediators, there is redness that is there during the active phase of the disease. And that will give you that reddish pink appearance of the promontory which you see through the tympanic membrane. That sign is called as Schwartz sign, and Schwartz sign always indicates an active disease that's happening, that's going on now. It doesn't indicate the previous disease. Schwartz sign negative means the disease is not active, it has already occurred, it is not happening at the current moment. So this sign is called as Schwartz sign, which you see in otosclerosis. Now look at this next sign and tell me, what is this sign? Arun, I want you to answer this. You're seeing something here, reddish hue near the floor of the middle ear. What is this appearance called as? I'm waiting for all of your answers in the chat box as well. Very good. Grace, Arun, this is your rising sun appearance. See, brown sign is seen in glomus tumor, where on increasing the pressure in the extraordinary canal with the help of a seagull's pneumatic speculum, the tumor vibrates vigorously and then becomes pale. That sign is called as brown sign, which is a sign seen in glomus which you elicit, means you are going to demonstrate that sign by doing a seagullization. But here we are not doing anything, we are directly visualizing something. We are seeing a red reflex in the floor of the middle ear. This appearance is called as rising sun appearance. And this rising sun appearance is specifically seen in a condition called as glomus jugulare. There are two types of glomus, glomus tympanicum and glomus jugulare. So this rising sun appearance is specifically seen in glomus jugulare. So I hope all of you got it. Arun, I hope you got it. Hello, Dr. Hashirama. Prince, Aquino sign is when you compress the carotid, the red reflex becomes pale. That sign is called as Aquino sign. Okay, Ame, I can go little faster. If most of you want me to go little faster, I can go faster. Please mention yes in the chat box because that makes my life easier. Okay, so look at this image and give me your diagnosis. Okay, Hashirama also says yes. Okay, fine. So I'll go a little faster. Quickly tell me your answers in the chat box so that we can go a little faster. Very good. This is called as herpes zoster oticus, also called as Ramsay-Hunt syndrome, where you see vesicles in the area of distribution of the facial nerve with facial nerve palsy. Fine. So let's go to the next image. Look at this image and tell me what is this showing. What is this image talking to you about? Quickly give me the answers in the chat box. Just like the prior question, we'll finish the answer very quickly and go. Something that is pointing to you very clearly. In the external auditory canal, you see some white discharge with blackish brown spores. What is it? Yes, this is otomycosis. This otomycosis is a fungal infection which is most commonly caused by Aspergillus, okay, fumigatus, and followed by Candida. Then there is Aspergillus niger as well. So you have this infection most commonly caused by Aspergillus. Wet newspaper like appearance is the thing that you see. Now look at this image and give me your diagnosis. What do you think is the diagnosis based upon the image that you see here? I'll give you a hint. You see that there is a bulge of the tonsil. So when there is a bulge of the tonsil, what is your diagnosis? So Prince Davis is asking me if it's quinsy. What about others? So there are two differential diagnoses. Whenever you get a unilateral bulge of tonsil, there are two differential diagnoses that you must consider. What are the two differential diagnoses? One for sure is peritonsillar abscess, also called as quinsy. What is another one? So yes, peritonsillar abscess or quinsy is absolutely right. What about another one? Very good, Dr. Mahesh. It is your parapharyngeal abscess. Can anybody tell me which compartment parapharyngeal abscess, pre-styloid parapharyngeal abscess or post-styloid parapharyngeal abscess will present to you with a unilateral bulge of the tonsil? I am waiting. Which compartment, pre or post? Yes, it is the pre-styloid parapharyngeal abscess that will present to you as a unilateral bulge of the tonsil. In peritonsillar abscess, there will be no neck swelling. So if you see, there will be no neck swelling in a peritonsillar abscess, but in a parapharyngeal abscess, there will be neck swelling. So neck swelling is present. So this is how you differentiate whether it is peritonsillar abscess or parapharyngeal abscess in a patient who's got unilateral bulge of the tonsil. Okay, let's go to the next question. Now look at this oropharyngeal examination, shows you some bulge here on the sides of the midline. What do you think is the answer when you get a bulge on one side of the midline, a pharyngeal wall bulge on the side of midline? This is your midline. You're seeing a bulge on the side of midline. What will your answer be? Very good, Harita. This is your oropharyngeal bulge, showing you a bulge on the side of the midline. It is your retropharyngeal abscess. So retropharyngeal space are spaces that you have on the side of the midline. So if you have an abscess in this space, which typically happens because of suppuration of lymph nodes following adenoiditis and tonsillitis, so the abscess will be located on one side of the midline. Chronic retropharyngeal abscess is usually tubercular in etiology. Even that can present to you as a posterior pharyngeal wall bulge on the side of the midline. Now look at this abscess and tell me, what is the abscess? Do you see an abscess exactly in the midline? So when you have an abscess in the midline, what do you think is your answer? I am waiting for your answers again here in the chat box. A midline abscess, not on the side but in the midline. What do you think is the answer? Very good, Rene. It is a prevertebral abscess. Very good, Hashirama, Sarvesh. This is your prevertebral abscess. Okay, so retropharyngeal abscess presents to you as a pharyngeal wall bulge on the side of the midline. Prevertebral abscess presents as a midline bulge. Parapharyngeal abscess and quinsy present as a unilateral tonsillar bulge. In parapharyngeal abscess, there will be a swelling in the neck, but in peritonsillar abscess, there will be no swelling in the neck. So this is something that you should know about the spaces and abscesses very surely, without which it's going to be difficult. Now this is something that you should answer in just 1 second and tell me the answer quickly. I'm waiting for your answers. So once we finish the all the images, we can have ask me anything session, because it's the new year and because we are ending the year and beginning a new year. So we can have a little bit of banter, funny banter at the end of the class, to just have a word of what are your plans of the new year and what are you planning to do, and what are your resolutions, so that we can have a quick check into all of it. Yes, very good. This is called as the potato nose, also called as rhinophyma. Although you know most things about rhinophyma, it is hypertrophy of the sebaceous glands following acne rosacea. It's known to everybody, but it's a question that can come, which is why I have included in this must know images. So look at this image, anterior rhinoscopy showing you something. There is something happening here. What is happening? Look at this and tell me. Again, I'm waiting for your answers in the chat box. So Prince Davis is saying septal hematoma, but in a hematoma you will get swelling on either side of the septum, not only on one side. So there's something like this. The septum has become like this. What do you call when the septum is not like this and it has become like this? What do you call that condition as? Very good, Sachin. This is a deviated nasal septum. Very good, Nirupam. This is a deviated nasal septum. So deviated nasal septum presents to you as a, as whenever you see and do an anterior endoscopy, you'll see a bulge of the septum on that particular side. So bilateral bulge, you must think of a septal hematoma, septal abscess, but unilateral bulge, you must think about a deviated nasal septum. So we know this is your septum. Just now we've discussed. Can you tell me what is this structure number 1 here that we've just discussed? We've not discussed, what is this structure number 1 and what is this number 2? Just tell me what is number 1 and number 2. Label the structures or identify the structures. Very good, Nirupam. Number 1 is your middle turbinate and number 2 is? Very good, inferior turbinate. On anterior rhinoscopy, usually we can't see the superior turbinate. If there is a deviated nasal septum, sometimes we may not be able to see the middle turbinate as well. So when we don't see the middle turbinate, usually it means that there is a high deviated nasal septum. Okay, now can you mark and tell me what is this structure 1? What is this structure 2 and what is this structure 3? Now this question has come many a times in the exam. So tell me what is 1, what is 2 and what is 3. Again, I am waiting for your answers in the chat box. Yes, 1 is the opening of eustachian tube. What is 2? A cushion behind the eustachian tube is called as? Very good, Nirupam. This is called as torus tubarius. Very good, Adraf. Hashrama, correct. So very good, Rohit. It's not tubercle, it is torus tubarius. And number 3 is the depression behind, which is called as fossa of Rosenmuller, which is the most common site of nasopharyngeal carcinoma. So the most common site is NPC. Now you see this is a posterior image of the posterior part of the nose, showing you a red vascular mass in the posterior end of the nose. So red vascular mass, it's an adolescent age child, male child, presenting to you with epistaxis, presenting to you with certain deformity of the nose. What do you think could be the diagnosis in this situation? No, Sachin, I am giving you age of adolescent. I am saying you the age is 14, 15. Rohit, presenting to you with bleeding, presenting to you with epistaxis, a red vascular mass. Very good, Tripti, Adraf, Prince, Nirupam, Rohit, Madhubala, Akib, Dr. GS, Sachin. Very good. It is juvenile nasopharyngeal angiofibroma. So juvenile nasopharyngeal angiofibroma is a condition that is seen in the nasopharynx. The most common site of origin is the sphenopalatine foramen, but from here the lesion goes into the nasopharynx and posterior part of the nose. So red vascular mass, epistaxis, bleeding from the nose, posterior part red vascular mass. Please think about JNA, and for that definitely you have bleeding, male, adolescent. That are three constant features that you must look out for. Now look at this image and give me the diagnosis. A infant born at birth presenting to you with inspiratory stridor. This stridor is present in supine position, gets relieved in prone position, present only during inspiration, disappears during expiration, increases with cry. What? The stridor increases with cry. What do you think is this? Yes, typically you are seeing that the epiglottis is folded upon itself, which we call it as omega shaped epiglottis. So this omega shaped epiglottis is a condition which you see typically in laryngomalacia. Laryngomalacia is a condition where there is excessive flaccidity of the epiglottis or supraglottis. Now look at this picture. Compare the previous with this. A 5-year-old child presenting to you with inspiratory stridor, fever, and is not able to breathe, and this increases with crying. There is a history of prior upper respiratory tract infection, and there is dysphagia, odynophagia, drooling of saliva. The child is sitting in tripod position and has been intubated because of respiratory distress and stridor. What do you think is the diagnosis over here? You are seeing that the epiglottis is red, swollen and edematous. What do you think could be the answer for this? Absolutely right. All of you have got it right. This is a case of acute epiglottitis. This acute epiglottitis, the update is it is caused most commonly by Streptococcus pneumonia. H influenza was one of the important organisms prior, but now it is Streptococcus pneumonia. Now look at this laryngeal examination and tell me what is it. I am showing to you bilateral symmetrical lesion at the junction of anterior 1/3 and middle 1/3 of the vocal cord. So at the junction of anterior and middle third of the vocal cord, small sessile lesions that you see. What is it? Yes, Prince and Sachin, you are right. In epiglottitis you do get the thumb sign in X-ray, right? So Akhil, this is bilateral, this is not unilateral. Whenever we talk of unilateral lesion, think of a polyp, but when we are talking of bilateral symmetrical lesions on the same symmetrical surfaces of the vocal cord, we are talking about vocal nodules. This is also called as teacher's nodule, singer's nodule, etc. because of excessive voice abuse. Now can you identify what procedure is being done over here? Look at this image and tell me what procedure. Yes, Tanu, it is also called as screamer's nodule. So look at this image and tell me what is this procedure that is being done over here. Yes, so typically you can see that a myringotomy knife has been inserted into the tympanic membrane to make a opening in the tympanic membrane. This procedure is called as myringotomy. And a myringotome, typically there are different myringotomes. Joseph's myringotome, Lucas myringotome are ones that we use commonly. So myringotomy is a procedure where you do a opening in the tympanic membrane to release the contents. It could be effusion which is sterile or effusion which is infected in ASOM, or in SOM which is sterile. So to release out the contents out, you do a myringotomy. So what is this procedure? In ASOM Basir, you will do in the posterior-inferior quadrant. In SOM, you will do the myringotomy in anterior-inferior quadrant. Okay. Yes, typically in patients with serous otitis media, non-suppurative otitis media with effusion or glue ear, what we see is there can be effusion and that might not come out completely. So to ventilate the middle ear, we are going to use temporarily a tube. This is not a permanent tube, this is a temporary tube which is called as grome. This helps in maintaining the ventilation from the external ear to the middle ear. So air will go from the external ear to the middle ear, making the ear dry. So this is used only in patients with serous otitis media. Now look at this instrument and tell me what is this particular instrument used for. Yes, I am waiting for your answers in the chat box. What is this instrument? I'll tell you that there are equal number of prongs on both the sides. 1, 2, 3, 4. and here also 1, 2, 3, 4. Yes, but name of the mastoid retractor, this question has come in the INI set examination, which is why I am giving some importance to this question. So please tell me what is the name of this mastoid retractor. Not shortcut, but I want a complete answer for this question. Very good, Nirupam. This is called as the Mollison self-retaining hemostatic mastoid retractor. Yes, so this is called as Mollison's self-retaining hemostatic mastoid retractor. Okay, now look at this image. This is also a mastoid retractor, but you see there are 1, 2, 3, 4 prongs on one side and 1, 2, 3 prongs on another side, and one prong is longer than the rest of the prongs. What would you call this type of a retractor? Where one prong is longer than the rest of the prongs, what would you call? Very good, Dr. Hashirama. This is called as the Plester's. So previously was Mollison's. This is called as Plester's hemostatic mastoid retractor. Now let's go to the next mastoid retractor. You see only one prong on one side, 3 prongs on another side. What is this mastoid retractor? Again, I am waiting for your answers in the chat box. Yes, Hashirama, L is for longer in Plester's. Yes, this is called as the, very good Dr. Hashirama, this is called as the Perkins mastoid retractor. So in Mollison's, equal number of prongs on both the side, 4 into 4, 3 into 3, that's how you will see in Mollison's. In Perkins, you will see only one prong on one side, which is longer, and the 3 or 4 on the other side. In Plester's, it may be equal arms or unequal arms on both the sides, but one of the prongs is longer, that is your Plester's. Okay. Now, can you identify this triangle which is given in the image here? I am waiting again for your answers. Correct. So this is called as Mac-Evans triangle. This is a triangle which is a surface landmark for identifying the mastoid antrum. So when we want to identify the mastoid antrum, you will have to mark this triangle. The first one is your superior temporal line. This is a true landmark. The second landmark is an imaginary line that you draw from the posterior wall of your external auditory canal. So this is your anterior wall, this is your posterior wall. So an imaginary line drawn from there, and the third line is a tangential line drawn to the first line and second line. This is called as the triangle that lies between these 3 lines is called as Mac-Evans triangle. If we drill this and go inside, we will reach into the mastoid antrum. Madhubala, it is a surgical landmark, but when you're doing a surgery, you need to have surface landmarks, because without having surface landmarks, where will you drill or where will you take the bone out to reach the antrum? So to do a mastoid surgery for a cortical or a radical or a modified radical, the first thing is reach the antrum, and the surface landmark for the surgery to reach the antrum is Mac-Evans triangle. Okay, so look at this and tell me, what is this? Is this cortical mastoidectomy or modified radical or radical mastoidectomy? Okay, so very good. What we see here, this is your external auditory canal. What you see here is the mastoid. Now between the external auditory canal and the mastoid, you see this bone. This is the posterior wall of the external auditory canal. Now if we don't remove that bone and if we keep it intact, we call it as canal wall up procedure, or also called as intact canal wall mastoidectomy, also called as cortical mastoidectomy, also called as Schwartz operation. So these are all the names for the same surgery: canal wall up, intact canal wall, cortical mastoidectomy and Schwartz operation. The principle is this bone should be intact. If you take this bone out and combine the external ear, middle ear and the mastoid together to form one single cavity, then you call it as modified radical mastoidectomy or canal wall down surgery. Now identify these instruments. Yes, I am waiting for your answers. What are these instruments? Yes, this number one is Thudicum's nasal speculum. This one is called as Killian's nasal speculum. So basically this has a self-retaining screw, so that when you open it, you can tighten the screw and keep the cavity open. Like for example, if you see, this is your Killian's nasal speculum. So when I am opening the nasal cavity of say a patient, I want this opening to be like this. I don't want to keep holding this instrument always like this, because I want to give one, fix it up and then give it to my assistant to hold it. So I will just twist the screw and I will just hold it like this, and then I will just ask my assistant to hold. So you see, this opening will remain as it is. So this is self-retaining. You don't have to do anything. The screw will fix by itself and keep the blades open. But in Thudicum's nasal speculum, it is non-self-retaining. So self-retaining is your Killian's, whereas Thudicum's nasal speculum is non-self-retaining. Now look at this instrument and tell me, what is this particular instrument? So look at this and tell me, what is this? So Amay, there are different types of speculums: Cottle speculum, Killian speculum, so many of them, but basically self-retaining one is Killian's. You can have a similar one without the self-retaining one also. Okay, so the self-retaining one is Killian's. Now you see, this is an instrument which has a bend here. So when you have a instrument or a mirror which has a bend, it is a posterior rhinoscopic mirror. And in posterior rhinoscopic mirror, the angle at which the mirror is facing is upwards. It is not facing downwards, it is facing upwards. So this instrument is called as St. Clair Thompson posterior rhinoscopic mirror. So St. Clair Thompson posterior rhinoscopic mirror is used for doing posterior rhinoscopy. So as to assess the posterior part of the nose and the nasopharynx, to check that we do this. So angulated one is posterior rhinoscopic mirror. Straight one, you will have a mirror which is straight. That is called as your indirect laryngoscopic mirror. Now look at this and identify what procedure is being done over here. So in the nose, I'll give you a clue. This is your septum, and the mucoperiosteal flaps and the mucoperichondral flaps have been elevated on both the sides. So tell me, what procedure are they trying to do over here? It's not about the forceps Revati, I'm asking you about the procedure. Very good, Basir Qureshi, it is right. Very good, Amay. It is SMR, submucosal resection of the septum. If you make incision only on one side of the septum, elevate the mucoperichondral and mucoperiosteal flaps only on one side and correct the deviation, we call it as septoplasty. But if you made incision on both the sides and elevated the flaps on both the side, then you call it as SMR. So in submucosal resection, the flap elevation is done on both the sides, whereas in septoplasty, it's only on one side. Okay, so with this we finish our class for today. Before we end the class, I just want to have a quick ask me anything session, because this is the last session that I'll take for this year on YouTube from Unacademy. Again, I'll come back in the month of January to take my next YouTube session. So just to have a little bit of fun with all of you and wishing all of you from my end, or to ask whatever you want to ask me, I'm giving this opportunity of 5 to 10 minutes that we can have just a quick discussion or quicker fun banter, or whatever you want to talk, or whatever you want to say, or you have any wishes for me, anything, you can let me know in the chat box. Wishing you all actually a very, very, very happy new year, and may God bless you all abundantly. May you all get the seeds of your choice that you've been longing for and thriving for since a long time. And I'm sure each one of you is putting your best game on and best effort on, but just keep going. Just don't think of the end result, just keep going on. Okay, my prayers, my good wishes are with each one of you. Sachin, ENT question in NEET PG 2023. I wish I had the opportunity to go forward in the time machine, go and look or have a peep into the question paper, come back into this time zone and give you the answer. But unfortunately, I don't have such time machine to help you with. So I'll just say I'm trying my best to help you out in the ways that I can, like to help you with must know images, the last minute topics, and certain things that you must definitely read before your examinations. And I'm hoping and guessing that they will come in your examination, but let's see. Dr. Hashirama, usually in NEET PG, what we see is about 8 to 10 questions coming from ENT. That's like the bare minimum number of questions that we get. Sometimes more, sometimes less, but most commonly it's between 8 to 10 questions that we have. Thank you, Grace. You have heard the recorded videos. The Vitals one is the new recorded video which I have recorded just a few months ago, which contains all the content of ENT, at least the must know for your examination. It is a 34 hour class. So if you go on a 2x mode, you will be able to finish it in 20 hours, 25 hours max. So I'm sure all those who want to just finish ENT in a very fast way, and you know the subject or you don't know the subject, this is one such video. At least you should try for once, I will tell you. Thank you, Nirupam. I'm happy that you're getting help from my classes, and wishing you good luck and wishing you a very, very, very happy new year. Yes, any more questions from anyone else? What are your plans for the new year? What are you guys doing for the new year? Studying for new year, or going out with your friends, or what are you doing for your new year? At least tell me that in the chat box. I'm going to spend the new year with my family, so it's going to be just my family with my mother, father, brother, sister and kids. So it's just going to be a family party for us. What about you? Shirama is going to only study. Good. But do take a break in between. Just take at least 4-5 hours away. Just enjoy that night and get back to studies the next morning. Okay, Melvin is also studying, so I see a set of studious nerds in my class here, so I'm very, very happy to see all of you here. But yes, that doesn't mean you should not enjoy life at all. Please do take breaks intermittently. They are something that will refresh and reset and reboot you, so just do sometimes in between. It's not like you will indulge in it completely, but yes, do take those small breaks, because they are the ones that will set you happy and set you go to the next topics or next studies that you want to do. constant monotonous study also is going to certain time you'll just feel like you're studying but nothing will be in your brain. So just keep giving those intermittent breaks, it will help you. Okay, so Bashir is also studying and partying. Very good. That's the best way to go. Fine. So if you got no questions for me, then should we all say bye bye for now then? Anything else that you guys want to know, or should I say bye bye? Oh, Dr. Hashiram, I'm wishing you an advance birthday. 31st is a day that you were born, and my mother also was born, so I will remember you on 31st for sure. I don't know if I can message you because I don't have your number, but right now, wishing you a very, very, very happy birthday. Oh, it's your mom's birthday, so the same here. Okay guys, so then I'll take your leave for now and I'll see you all again. Until then, please take good care of yourself. Priyanka, you can find me on Telegram with ENT by Dr. Vyshnavi, and I'll be there. Okay, so whatever there, I'll be able to handle your queries there. Or even Unacademy app is there on Telegram. Just leave a message and tag me there, and I will be able to reply you back there. Okay. Okay, fine then. Take